So firstly, we just kind of wanted to touch base, and this is a very informal Q&A kind of style chat that we're having. We really want to continue the conversation when we get to the Congress coming up in May. But firstly, we really just wanted to touch base around what do we mean by primary care, because quite often there's a lot of different things that are going on out there in the literature. So for us in the special interest group at Wadham, we identify primary care as primary care health professionals as GPs, general practitioners, pharmacists, nurses, social workers, or really any health worker who works as the first point of contact for a person within the community health system. So we want to be really inclusive because there's a lot of us that work in the primary care setting that need to be involved when it comes to disaster management. So our vision as the special interest group and why we formed back in 2018, is for the future of disaster management to better integrate primary care health professionals, so all of us that work in primary care, for us to work collaboratively together with disaster health professionals, local hospitals, governments, and disaster management sectors to really ensure the best health outcomes for patients in all stages of the disaster management cycle. And you can find more on the Wadham website about the special interest group, and we'll touch on that a little bit more coming up. But what I really wanted to get in terms of our panelists and ask Libby and Penny is, why is primary care so important when it comes to disaster management? And maybe we can start with you, Libby.
Thank you, Kaitlyn. So I think if you're joining the webinar, probably you do have a good idea as to why primary care is important in a disaster. I'll speak a bit from the pharmacy perspective. So for those of you who aren't aware, pharmacists are a really important part of the primary care team. We're a pretty accessible health profession. People can just sort of wander into a community pharmacy and find us, no appointments really needed. So we really play a key role in being able to organise supply of medications for patients. We know a lot about around the legalities and supply issues that people can face in disasters. We know who the vulnerable people are in our communities. Like I know who in my community is on maybe immunosuppressant medication. I know maybe who's on opioid replacement therapy, and I know that they might be at a higher risk in a disaster. And of course, GPs have this knowledge too. It really enables us to work together to get the best outcomes for our patients. And I guess depending on where you're practicing, there's also a lot of extra skills that pharmacists bring to the table, such as performing immunization, doing basic wound care, a lot of acute response to disaster as well. So we really play a vital role in the team and can really contribute a lot. I think we've all been in a situation where we've been talking to a patient and they maybe don't know what medication they're on. We also know what all the drugs look like. We know what they smell like, which can be a pretty strange skill to have, but it's very useful in a disaster when someone says, I'm on something that smells like peppermint. You go, I know what that is. So really, I see us as an integral part of disaster response in conjunction with our GP and other primary health colleagues. Penny, did you have anything to add?
Yeah, Libby, look, and absolutely agree with all of that. I guess one of the things I think about the key roles of primary care and why they should be included is actually reflected in the title. So the title of this year's Congress is Complexity and Continuity in an Increasingly Challenging World. And one of primary care's key roles is actually around coordination of healthcare, which can be a pretty scary thing at normal times, but when disaster hits, the healthcare system gets disrupted. And people actually flood into general practices, they flood into pharmacists saying, what do I do, where do I go? And we know that from experience. And the coordination of healthcare has actually been proven to improve health outcomes. So we have research from Ma Singh, who shows that coordination by primary healthcare doctors prolongs life. We've got research from Starfield, which is well known, which shows the benefit of primary healthcare in health systems, increasing lifespan and well-being, and reducing mortality from heart disease and stroke, and decreasing infant mortality. And the evidence suggests that also that health's improved in areas that have an increased number of primary care doctors as well. Kaitlyn, could you go to that slide? Yeah. So how the way that occurs and what are the characteristics of primary healthcare are reflected in this graph here in the middle line. So you've got sort of available first contact, you've got whole person, you've got continuity, which is either relationships. So, as Libby was saying, we're related, we know these people, we know them well, we know what their health history is, we know exactly what medications they're on, and we know who's more vulnerable and who's more likely to need help and who's going to be self-sufficient and not need that. Comprehensive care, coordination, and within the community context. So I think that, for me, one of the key reasons that primary care should be involved is that it improves people's health. And the second reason really is that pharmacists and GPs are in the community when disaster strikes, and they're in there before the disaster struck, and then they're in there after, long after everyone's left. So that creates an incredible opportunity through PPRR to actually, in the early stages, for disaster risk reduction and for preparedness of patients, and then during the actual event for maintenance of that usual health, so continuity of care, for also for early surveillance and early intervention during the disaster. So picking up really early, the diabetic care is actually starting to become worse. And we've got lots of research that shows the health effects of disasters and how diabetic care often deteriorates in the first 3 to 6 months. And then if you've got someone who's monitoring that, it will improve by 9 months. Even Katrina, where the health services were disrupted, you don't have that. It can continue to deteriorate to 18 months. So there's also a lot of information on that. Surveillance is really key. During the Black Summer bushfires in 2019 on the east coast of Australia, one of the things we had was, I was actually a GP liaison officer in the Emergency Operations Centre, and we got a lot of valuable information from our pharmacists and GPs on the ground who are working in evacuation centres, working in their practices, saying this is what we need, this is what we're seeing, this is what we need you to do. And then, of course, there's that ongoing surveillance for the years afterwards. So months and years afterwards, when people have other people may have forgotten about the disaster, the primary care professionals are living that within that community. They can tell when there's an increase in issues around mental health or other issues, and they can watch for those. And even down to what we recently know now about, decreased academic performance in school children, behavioural change in children, all those things continue. And we've got a lot of information from following the Christchurch earthquakes from our GP colleagues around people coming in every time there's a tremor at 1 year or 2 year to their general practitioner and saying, this is upsetting me. So I think there's a lot of other reasons why primary care should be involved, but to me, they're the key ones, I think. Kaitlyn, did you have some thoughts?
No, I think you guys have covered it really well. I guess while you're going, Penny, I'd really like to know more about historically, how has primary care been involved in disaster management in the past, and perhaps a little bit on how they're involved now from your perspective.
Yeah, so I think that's really easy to answer, sort of not really much at all. But I guess the answer is in a very ad hoc, spontaneous way that hasn't been documented. So I first began working in the space in 2007. And in Australia, GPs and pharmacists really weren't involved apart from, in random ways, which is actually not safe. To have them disconnected from the system is not safe. I joined Wadham in 2014, and there was not a lot of discussion around primary care. I latched on to one or two of the GPs that I met and got very excited. And then in 2017, though, in Wadham Congress in Canada was fantastic because we had the New Zealanders who had that huge experience from Christchurch. They'd prepared for a pandemic and they'd responded really well to an earthquake, which shows how it's an all-hazard approach that needs to be taken. And so they were presenting what they had done. And that was like a light bulb, and it was a wonderful moment. And then following that in 2019, in Brisbane in Australia, we actually had our first primary healthcare stream, and you guys were there, and we had input from Asia, Oceania, and New Zealand again, and it was a great meeting. So it has been a very vacant space, and probably the worst part about it is that any of the involvement of GPs and pharmacists have been poorly documented, and so we don't even know how they were involved. Kaitlyn, what about in pharmacy?
Yeah, you're definitely right in the sense that it's not well documented. We sort of get to this point where we all, respond, we step up, we do amazing things for our communities, and then we all revert back to whatever, normal operations. So I think that's definitely a missing space. You're right. Toronto in 2017 was the first time that pharmacy had a stream for Wadham, which was amazing. And then we together decided, when we came together in 2019 in Brisbane, that we're all involved in primary care and that we need to sort of come together. In terms of the pharmacy space, there's been a little bit of research, and I'll just go to the next slide, around how pharmacy has been involved based off the literature, and a lot of it does come out of the States purely because of the lack of literature that we have around pharmacist involvement. But really sort of the role of pharmacy has been evolving as time has gone on. Previously, it was very much a logistics role, just making sure that we had enough drugs and supply. Then sort of as, you know, we headed into 2001, 2003 with the different anthrax crises, as well as the SARS outbreak. You know, there was a bit more, all pharmacists have some knowledge in terms of some bioterrorism roles and different things in terms of drugs and what medications you can take prophylactically with SARS. And then sort of as we headed into 2005, sort of with Hurricane Katrina, it was identified that, well, you know, primary care does have a role to play, and pharmacists can do a little bit more clinically, you know, both pharmacists and GPs. This research is specifically pharmacist space, but everyone in the primary care space can offer a lot of support and a lot of surge capacity in terms of healthcare resources. And then I think something that was unique around, in particular in Australia, is the thunderstorm asthma event that happened in 2016, and in Canada here in the Fort McMurray wildfires that happened as well. That required a lot of response and a huge healthcare resource in terms of the community and in terms of primary care. And then, of course, we all know about COVID-19 and we're still living it. In terms of that impact and how it's evolving, the pharmacist roles internationally is quite interesting. We've done a little bit of work in that space to try and document it and get more information out of there. But I think that's the biggest issue, is documenting what we do in primary care, because we're so good at just getting on with our jobs and making sure that people's needs are met. Libby, do you have anything to add on that?
No, I think you've both covered it really well, and there's a sort of a big unknown hanging over us at the moment as to where to from here. I think anecdotally, from the new literature that's coming out, and even seeing, we've had a few big disasters in Australia where there's been a lot more media focus on what primary care has been doing in those disasters. So I'm hoping that it's sort of making its way into the current a little bit more in terms of mainstream media. So hopefully that will help with leveraging and improving roles, and improving some of the resources that are available to support this as well.
Yeah, look, and can I just comment too on what Kaitlyn was saying about Hurricane Katrina? So there was actually a great paper by Edwards out of the States, out of Texas, following Hurricane Katrina, and it just reflected that that issue around the volume of care that primary care can see. So I know in Australia, for example, it's about 5% of daily new encounters are seen in EDs, and about 95% are seen in general practice. So it's a large volume of care that GPs can see. I know that the Christchurch GPs, when people were flooding out of Christchurch, they were seeing thousands. They set up a triage area and they saw thousands of patients that would otherwise have had to go through hospitals. And in Texas, for example, this surge that was flooded across the border to Texas, I think there are about 1,600 people were triaged in this spontaneously set up triage centre by the local health centre during a 2-week period, and only 148 people actually went to the hospital. And so it really took the weight off the other services, which need to be kept for really high acuity staff.
Absolutely, like exactly what you're saying. You know, a lot of the issues are around chronic disease exacerbations, and sometimes it's just a lack of access to services or to medications. So what are patients going to do when they don't have access to, you know, their Meals on Wheels services, or the community nurses that usually go into their homes, and all these different community services and healthcare that we provide in the community? In a disaster, if we don't offer these and if we're not included, then quite often these patients are, exactly as you're saying, clogging up our tertiary healthcare that needs to be dedicated to more acute, high acuity needs. So if we can increase our capacity and increase the health resources available through our surge capacity in the primary care, then we can help mitigate some of these issues and stop them before they exacerbate as well, by ensuring continuity of care as well. Libby, did you have anything?
Oh, I was just going to say, on those amazing examples that Penny brought up, that those things don't happen overnight either. Like, you need those pre-existing relationships to really make it happen during a disaster. If you're waiting until a disaster strikes before you reach out to your colleagues to figure out how you're going to manage it, you're going to have a tough time. Like, you'll probably get through it, but it's going to be a hard slog. So having those conversations beforehand is really important, and something that I think we probably all need to improve on globally.
Penny, what do you think is the biggest barrier in terms of getting more involvement from primary care?
So look, I just following on, I guess, from what Libby was saying, I've been working in this space for 15 years. And when I first arrived in this space, I was pretty amazed that we weren't involved, and I had never thought about being involved. And it's taking 15 years to develop relationships and to develop resources and to make changes. And I feel that now we're just starting to catch up with New Zealand, who are the gods in this space. I defer to them always. Yeah, look, I think the I guess what really is happening is we've had a lot of change, as Libby was saying. So we've had, as you said, a lot of media. We've now got a change where both GPs and pharmacists realize they have a role through all the work that's been going on, and all the advocacy and stuff. And we've actually also got disaster management now going, oh, okay, we can use GPs. We understand how to use them, how they're useful. But there's still lots of issues around how we communicate with the, between the disaster management group and the PHNs, the disaster management groups and the GPs and the primary, other primary care providers. So I think what I've seen is a huge change where we've now got a system that actually starts to include what we call primary healthcare networks in Australia. So in Australia, we're divided into 31 groups of health districts, which represent primary care. And these are now being linked in to disaster management groups. And we've currently, I was just speaking yesterday to the primary health networks in Western Australia that have come together as a group. There's 3 of them, and they're involved in the Kimberley floods that are going on at the moment. So for the first time ever, last year I was working with them on their planning, on their healthcare plan and their disaster preparedness plan. And now, before they've even finished and got it signed off, they're actually involved in these floods, and they're in the meetings, and they're trying to work out how to support the communities out there that are very isolated, very remote areas, and they're being respected and included, which has been pretty exciting. And I guess the other thing I want to just mention while we're on this is there's been a huge amount of uptake from the colleges and the professional groups in Australia. So in Australia, the pharmacy groups and the GP groups are now developing a lot of resources. And so there's a lot more resources and a lot more conversation going on around that. And sorry, Kaitlyn, what was your question?
Just any additional barriers that you see, like why it's such a challenge for primary care?
So I think that there's a lot of barriers, and I think slowly through this time we've been addressing them. So through having this linkage now through these health districts with the public system, we're addressing the issue between the private divide of general practice in one camp, and most of primary care is private, so pharmacists are private businesses as well, and the public disaster health system. So that's been a really huge issue, and how do we link that in? So in Australia, we've done it through these health districts. And the other issue has been really a lack of understanding by primary care. So we've got a lot of work to do in primary care. We didn't understand how disasters work. We didn't even understand there was a system. So early on, when I was involved in this, we had GPs saying, we need to be involved. Why aren't they letting us in? We need to be able to rush in, not understanding there was actually a system there that we need to link into. So I see that the key part to the barriers that occur is primary care working with disaster managers to work out how to perform that ongoing linkage and communication, and what our roles are, what we do. One of the biggest questions early on is, well, what do GPs actually do? Do they just write scripts? And we feel we do a bit more than that. But it's telling us, having that conversation about why we should be involved, how we should be involved, and then what's feasible, because we also can't just pull GPs and pharmacists out of a private business to have meetings in the middle of the day whenever that needs to be done for preparedness. We can't pull them out for 3 days at their practice when they would be working in their practice anyway. So, there's a lot of issues around how we navigate the boundaries between what GPs and primary care can do and are able to do, and what the public health system requires.
Yeah, it's a really good point. And I think something that's changing, at least what I've seen in the pharmacy profession at the moment, is the change in accepting within the primary care space that pharmacists see themselves as needing to have a role. I think in terms of, well, since like Libby and I have gotten interested in this space and done a lot of work in this space, is at the very beginning, I remember a lot of people being like, oh, but pharmacists just like, you know, put labels on boxes or, you know, count pills, like they don't really need to be involved, it's fine. Where it's like, well, no, actually there's a whole realm of things that pharmacists need to be prepared for in themselves, because there's a huge expectation that they're going to keep their pharmacies open and that they're going to be available in the response and recovery, yet we don't train them in terms of the preparedness and the prevention and mitigation. So just a slide that I can share based off some of the COVID research, and I don't want to turn this into a COVID conversation, but just this bigger bubble around public health, and pharmacists having a role in public health really became visible to pharmacists themselves during the pandemic. So this is a really new fluid space where pharmacists are beginning to recognize that primary care needs to be involved in disaster management. And part of that is actually understanding exactly what you were saying before, Penny. Some of the basics is what is disaster management, the structure, like the whole thing's there, and primary care have been responding on their own in the silo on the side. So how can we get them integrated and knowing each other? You know, even just knowing the phone numbers of the disaster management system within your community, so you can reach out and be a part of it. Being, you know, some of the different conversations. Libby, did you have anything to add, Penny?
Oh yeah, look, I was just going to say, yeah, look, I think it's really, really important that we also remember, though, there's a safety issue. And one of my main reasons for being involved in this space is I've been worried about the safety of primary care providers that have stepped up valiantly to help their communities during disasters and being told they're not needed, or going in and doing dangerous things on their own and not realizing what the system is. And so, and then afterwards, you know, there's a risk that they're traumatized as well, because they're doubly vulnerable. They're not only emergency responders, in my opinion, but they're also locals who live in that community, who have friends in that community, who have children going to school in that community. So they are really doubly affected. And so I think one of the probably the key reason they need to be involved is that they will be involved anyway, and we need to protect them. So we need to bring them into the systems.
Absolutely, absolutely. Anything that you wanted to add on that, Libby?
No, I think we could probably talk about it for 2 more hours, even just between the 3 of us. So nothing more to add. Thanks.
Awesome. Well, maybe just in the interest of time, I'll move to the next question, unless there's anything else either of you wanted to add. So then I guess I want to ask both of you around why was it that we formed the Wadham Primary Care Special Interest Group? Who wants to go first?
Penny? You can go.
All right, maybe I'll start. So I can start by sharing the vision and the goal, like the vision. Well, I already shared the vision, but the goals of what we're trying to attain from the primary care SIG. So really, this is not an isolated issue, as we've sort of talked about, you know, back in the Toronto conference in 2017. Penny, you guys had a GP session, like Libby and I, we had a pharmacy session. And so we were all sort of in these different siloed areas of our response, but really primary care works together. We work together in everyday practice in our community. So why, when it comes to disaster management, are we siloing out our different contributions? So part of that was we really wanted to come under one umbrella and really understand that a lot of the issues that we face in pharmacy are very similar to the issues that are faced by GPs in their practice. What you're talking about before, Penny, about protecting our healthcare professionals working in the community as they are living in the community and they know their patients. And they're going to be there for the recovery phase, you know, after everyone else disappears as well. So some of the goals that we have decided that we're working towards in terms of this SIG is fostering the professional growth of our members and part of the primary care special interest group of Wadham, to facilitate the increased access to professional information for all Wadham members. So a lot of it is around awareness of what do pharmacists do, what do GPs do in terms of disaster management in their communities, how can they be helpful? Just starting some of those conversations. Assisting with the organising of the primary care response stream for the Congress. So that's what's coming up in May, and we're really excited to meet everyone in person again after so long and to talk about our different experiences. Increase the contribution of the disaster primary care health professionals and organisations in our disaster PPR, prevention, preparedness, response and recovery cycle, through interaction with the other SIGs and other disaster professionals. So we don't want to do this on our own. We want to do this in collaboration with the system, and making sure that the system works for both primary care as well as disaster management, and that we're not making a lot of assumptions about the other group. Because I think that's kind of where we have been and where we're trying to come away from. And we also want to support research and evidence to develop more of the primary care and get a lot of the evidence of what's happening documented. So that way we can move forward from a positive position. Penny, what have you got to add?
Yeah, so look, I think that's really important. I think one of our key issues is that we would really like to support other countries, other areas, other groups. Obviously, we're, you know, as noted in the chat, we're all from a similar region, Australia, we're in Canada. We're very keen to involve people from other parts of the world, and we're trying hard to get that involvement. It's not easy because it's a group that's been forgotten. It's a group that doesn't need to know that to be involved. And I have been approached at Congress by a number of, like, I remember a radiologist, a community radiologist approaching me, a physio, a number of sort of isolated people going, we want to be involved, but we don't know how. So we would really like to act as a resource and a support for other professions and other regions that want to develop it, and we're really happy to freely share resources. And we also want to, I guess one of our key things is to encourage documentation of what people are doing. So even if you're involved just in a disaster, if you're involved in a disaster, document it, recount, do a recount, anything, just get it out there, send it to us, we'll publish it. We really need to let other people know that we're actually not invisible, that we're actually there doing things. So I think that to me is really one of the most important things. Libby?
Yeah, I totally agree, Penny. And it's amazing whenever Kaitlyn and I run some disaster workshops together, and whenever we're in these workshops, the people in them have the most amazing stories of what they've experienced, what they did, the lengths they went to, how they managed in a disaster. And when you ask them if they've shared that with anyone, they're just like, no, what, would anyone be interested? Like, yes, they would be. And it could help other people to learn about response and maybe even how to prepare themselves for something that might happen. But I totally agree with all of your points, Kaitlyn and Penny. And I think the real crux of it was that the primary care SIG, as Penny alluded to a little bit earlier, was really sort of formed out of this gap in what was happening, and this need for primary care to be represented and to be included in the disaster management space. And having a presence somewhere like Wadham is just absolutely amazing, to be able to create networks with disaster management and health professionals. It's a really special space for us to be in, so it's really great.
Definitely. So if we have convinced you of primary care's important place in disaster management and why we need to be there, or you want to get involved, to be able to reach us, you can get through us in terms of the primary care special interest group on the Wadham webpage. On there, we've got some newsletters that we put out periodically, the position statement that we did in partnership with the Oceania chapter, the contact information for us, as well as any expressions of interest to join the special interest group. But we really would love to meet everyone in person in May. If you're heading to the Congress, we'll all be there, and would love to see you and hear about some of your amazing stories and how we can help you in your space. But I guess as we head into the Q&A portion of the panel, if there are any questions, please put them in the chat or in the Q&A, or raise your hand for us as well. But just one final comment from both of you around what is the one thing that you're looking forward to in terms of the Congress and this primary care space. We can go with Penny first.
I guess just increasing the visibility of primary care in this space, and also hopefully getting some really exciting new ideas on how we can be involved, because we're always looking at how to do that. I did see it at one of the Q&As down there. I saw someone mention that they're worried about how to involve primary care because they want them doing their own work as well. I just want to respond to that if I can while I'm doing this. Just that that is the aim. The aim is to support and build up primary care within its own practice. So we've actually in the disasters we've been having recently, there's been a lot of support to keep general practices and pharmacists open longer hours, keep GPs and pharmacists working in their own practices, and only when necessary, bringing them out to work in evacuation centres or things like that. And I think that's part of why we need to have a plan, because sometimes what will happen is that they will get pulled out and then they close their own practices and they don't realise, and that's just not going to work. So that's why we need to prepare and plan. And I think if we can have a lot more communication with disaster managers across this space, I think we can come up with a good solution.
Definitely, and sort of anecdotally based off some previous research in terms of the New Zealand model, if we're referring to that, is they were able to come up with a lot of good policies around how to protect pharmacies, private business in terms of patients and their dispensary data and things like that. But then in an emergency situation, being able to appropriately share that between pharmacies that were closed and opened, and making sure patients got their care. So I think there is a lot of ways that we can do that and make sure that first and foremost, we're all there for our patients. That's why we get into this business. And so I think there is a way to manage that delicately. And really it's about bringing them to the table in the first place, because they're not always necessarily represented. But on that, is there any final comments? Otherwise we'll move to the question time, Libby or Penny. Oh no, Libby, what's your one thing you're looking forward to for the Congress?
Well, I'm really looking forward to meeting a lot of new people face to face, and just having those discussions, hearing stories, and learning from everyone is sort of my big thing, as well as going back to the homeland. I was born in Ireland, so I'm really excited to be able to go back there after so many years of COVID for a visit. And yourself, Kaitlyn?
Oh, I think networking and being able to meet a lot of you in person, and perhaps work on different ways that we can collaborate, we can get this evidence out there, make some noise around the importance of primary care, especially on the back end of COVID, if we are actually on the back end of COVID, being able to promote the SIG and promote the amazing work that primary care have done, especially in terms of COVID. We have done a tremendous job to help people get through this. And I want to make sure that we honour the people that have worked on the front lines for a really long time, and make sure that their stories are heard. So I think that's probably what I'm most excited for. But I'll hand over to you, Andrew, to moderate for the Q&A.
Great. Thank you so much, Kaitlyn, Libby, Penny. I'm going to keep my webcam off because I'm doing this from home and the lighting's very bad here. It looks like I'm in a cave. So we'll just keep the camera off and the Wadham logo up on the screen for me. So my first question I have is, and you may have touched on this a little bit in the presentation, but why has primary care not been included in disaster management until recently? Like, is there kind of from your perspective, why has that happened?
Can I have a go at that, Andrew? I actually got asked this in a royal commission as when I was an expert witness, and I must say, my jaw dropped to the ground. I struggled to answer it, but it's my thoughts are that they've just been really forgotten. Not really, no understanding of the role. But probably most predominantly is that they're disconnected in the healthcare system. And so even in usual times, we're a bit disconnected. So in Australia, there's a private system, healthcare system, and there's a public healthcare system. GPs fit in the private system. And so they're paid by seeing patients. They're not paid. So I've gone out many times in disasters and I haven't been paid, because that's not where I get my income from. Whereas as a hospital person or a public healthcare system person, that's then funded. So I'm not saying about funding, but it's about different systems. So in terms of meetings, I have to give up half a day or a day of work, which is my income, to go and sit at a meeting where everyone else is part of the system, and that's part of their work, and it's not part of my work. And I'm stepping out of the usual to do it. So it was very hard to find. It's still very hard to find GPs that are experts in this area, and so we get a lot of requests to talk, to go and have meetings, but there's a limited number of us that can do that still. So I think it's really about the disconnect between the systems of public and private.
Yeah, definitely. And just to add to that is definitely the overlooked piece. I remember sort of when I was first doing this space and I was going to a couple of different conferences and different things, and people would be like, oh, like, where are you from? And I'm like, oh, I do research with disasters in pharmacy. And they're like, do you really need to be involved? And I'm like, well, when you're evacuating someone from their home, like, people come with a lot of medications, are they taking their medications? We're obviously focused on the person and bringing them to safety, but there's so many other things to people, and medications is being such a big one. And how are you going to supply that? And by putting them in the tertiary system, you're using resources that are better allocated elsewhere, yet these patients' needs still need to be met. And there's an entire untapped workforce of primary care that can help cater to these patients. So yeah, definitely.
Great. We do have some questions coming in here through the Q&A. We have a few people with their hands raised. I'm going to go ahead and go with a question here from Greg Banner. Patricia, I just sent you a response to make sure you're still interested in asking your question verbally, so let me know in the Q&A. Greg asks, are there any attempts by Wadham or elsewhere to create disaster planning and operation standards for the groups you include primary care? List of qualifications, planning tasks, things which the primary care community should be able to do for disaster work.
Look, yes, I'm happy to. We're in process at the moment. So there's a huge amount of work going on in this, because we're not thinking that GPs and pharmacists and primary care can just suddenly get involved without training. So there's actually been already a lot of development of resources around disaster systems to educate GPs, particularly. I'm not 100% sure about pharmacy. We're developing at the moment guidelines right at the moment, because we've had big flooding in Lismore and we've got the flooding going out in the Kimberley. We're devising with the Royal College of GPs in Australia and the PHNs, the primary health networks that I've been talking about, to create guidelines for the role of GPs in disasters, in evacuation centres. And the reason for that is that there's been about 40 GPs over the last 2 years sent out to evacuation centres up on the Northern Rivers region. And there needs to be a bit more, as someone mentioned in the chat, a little bit more control over whether they're staying in their own businesses and we're supporting those businesses, or whether we're moving to evacuation centres. For example, a couple of the major practices in Lismore were flooded, and they see thousands of patients a day. And these patients were then all having to find somewhere else. They were being sent to evacuation centres, and the GPs were actually manning those evacuation centres, when what would have probably worked a lot better for everyone was to support those practices actually getting back to business, make them a priority in terms of power and infrastructure recovery, which they're not necessarily at the moment, and get them up working and functioning. And then you have actually less need for the evacuation centres. So there's a lot of work going on in those guidelines. During the pandemic, we had non-stop guidelines coming out for GPs. We were constantly, we had the GP respiratory clinics, which I know they had in New Zealand back in the swine flu pandemic. And we were creating guidelines for those as well. So there's been a lot of work around, we don't call them standard operating procedures, we call them more guidelines. But there's also a lot of scope to have more involvement of disaster managers in those developments. I think that's a really good thought.
Great. Well, we're going to go ahead and try and take a question from the remote audience. Patricia Chappelle, if you're there, I'm going to go ahead and unmute your microphone if you'd like to go ahead and ask a question. It looks like she wanted to ask a question about Red Cross.
Can you hear me now?
Yes, we can hear you.
Yeah, I am with the Red Cross, been with the Red Cross since 2004, and everything you all are talking about is right on. Just really support you tremendously. Good. But I want to ask, how are you related, or have you interfaced with the Red Cross? And the reason I'm asking, that could be United States, Mexico, regardless, we're everywhere. But in the United States per se, we have really switched in terms of a high priority, in terms, because we have so many disasters occurring, in terms of mission adaptation, one of which is healthcare continuity. We are very much in the shelters. We understand what you're saying about where are the clients getting their pharmaceuticals resupply, their primary care support, etc. We are involved with the Medical Reserve Corps, etc. U.S. Public Health Services. So I'm just kind of wondering, everything you're saying is awesome. So how are you, or could you be perhaps involved with the Red Cross in supporting and extending your mission?
100%. Or Penny, you can go first. Oh, I was just going to say, for me personally, I'm a volunteer with the Canadian Red Cross in terms of disaster response. But 100%, like well, I can speak for myself, definitely interested in trying to integrate a lot more in terms of some of these organizations, because I think a Red Cross has such a big presence in particular, and can work very well and does work very well with the community in terms of response and preparedness. So definitely open to doing a lot more of that. But in terms of the SIG, we haven't quite got any of those relationships solidified yet. Penny?
Yeah, look, I think this is really important, Patricia. I've been involved with some of the welfare recovery groups in New South Wales when we've been recovering from previous disasters, and it's been fantastic. We've had all the different groups there, Red Cross included, and I've got some good colleagues in Red Cross that I regularly call and ask questions, and we interact. But the formality of it is really difficult and hasn't happened as much. When I first started in this space, I was most interested in recovery because I saw that recovery was the area where the biggest role for primary care was. You know, those months and years afterwards, when this huge burden of care was coming up with all that deterioration in healthcare, people's social determinants of health, all those things change. And, you know, Red Cross is so important around the early, the evacuation stuff, which is, we know it has a huge impact on health and health deterioration. And so obviously we need to link. That has been, unfortunately, what happened was I got distracted by the response because people go, oh, you can't be involved because you can't, you know, use response. And so that's made us have to work hard in sort of, I guess, justifying why we should be involved in response. And now we're actually really keen to get back to what I think originally was the real reason, is that recovery, that long recovery. And I think it requires working in more with the Red Cross and some of the other welfare groups. But it's an area that we haven't got to yet. We started there and then we left, and then we're hoping to come back to it. Would be really great to communicate with you. If any of you want to email us, we're really happy to have you email us individually or as a group. I'm really keen to get this space, you know, advanced. So a really good question, Patricia.
Great. We have a couple more remote audience members who have their hand raised. So we have Radwan Alberbandi and Graham Dodd. So I'm going to go with Radwan first. Graham, you'd be up next. Just bear with me here and I'll go ahead and unmute your microphone.
Okay, can you hear me now?
Yeah, we can hear you loud and clear.
Thank you so much. I will not take a long time. My name is Radwan. I am originally from Syria, from Damascus. I did my primary care training in England, and I did work in Australia for 2.5 years during the lockdown and the bushfire. And I work with refugees in Greek and in Jordan and in Yemen with Somali refugees. Currently, as I speak, I'm currently doing a fellowship in disaster medicine in Boston, United States. And actually, I was not aware about disaster till I went to Australia, till I saw the bushfire firsthand, till I saw the COVID. My practice was the first clinic that ran the testing for COVID, then immunization, and so on. The question is how to enforce or how to bring the disaster medicine to primary care or primary care to disaster medicine. Because if you speak to, there's a stigma around it. And the stigma is that only emergency consultant will be involved in the primary and disaster medicine. But it's more about management and decision making rather than skill. Nobody's going to ask me, go and intubate that person and so on. That's number one. Number two is the difference between the UK and Australia. Not only the billing system, the private and semi-private and complete private system in Australia, but also the computer system is different from practice to practice. Every practice can upload their own software, while in the United Kingdom, we have almost 1 or 2 software across the United Kingdom. what I'm trying to say, I'm trying to really to do, I need a help, first of all, to start with, really. I'm not here to give any suggestions at all. My dissertation about the fellowship in disaster medicine, my dissertation is about the destruction of medical facility during the war zones. So I will talk about Syria, Ukraine, Armenia, and other war zones, how they systematically destroy the medical services. But I'm really keen to do another search about how to enforce a primary care and how to bring the primary care to a disaster, because in Australia, I found it difficult a little bit because the cities are very well close to each other. But when you go to the rural area, you are a different dynamic altogether, and the space is wide. Maybe you need helicopter, you need other means to communicate and transfer. So logistically is also difficult, not only because of the distance, because it's a huge country. I'm looking for cooperation. I will be in Ireland, definitely. I'm looking forward to it, and I'm looking for cooperation. I'm looking if you can add my name to your mailing list, I'll be very grateful. And looking toward create a proper project about it in NHS, because NHS, we have a data and we have uniform data because we have uniform system and uniform software. That's it really. Thank you so much for listening to me, and have a very nice day. Thank you so much.
Thank you, Radwan. Can I answer that, Andrew? I totally identify with what you're saying around bringing primary care and enforcing primary care and disaster management. We had a huge problem with that. So one of the things that surprised me in working in Australia, and it's still the case, you know, we're not there by any means, we've got a long way to go, was that most GPs, so I did a PhD on this, most GPs interviewed said, oh no, I shouldn't be involved, I don't have anything to contribute. No understanding of the value that they brought. And so initially, that's been one of the problems, is creating an understanding amongst the GPs themselves of what they can contribute and their value. But then there's been other groups that have gone, oh no, I can just rush in and I can do whatever because I know how to do those emergency things, and I can just turn up on the day and do it. And so we've also had to work on that in terms of educating people around systems. So I think it's not so much about enforcing, but it's about educating in collaboration. And again, I go back to the point. I think what needs to happen is, what's helped us has been support from some disaster managers who we know well. So I've worked closely with a lot of disaster managers, and they speak a different language. And they often say the reason you're there, Penny, in the Emergency Operations Centre is to translate GP speak, because we don't know how to talk to GPs. And so that's sort of, I think, setting up the basic understanding of where GPs or where primary care, where pharmacists sit, exactly what their role will be, how they will interact with the other responders, and then having someone in general practice or primary care up in those emergency operations centres or local, state, or whatever, to actually communicate what's needed. I remember at one stage a disaster manager saying to me, oh, we were just going to put out, they were going to put out just 3 days of medications from pharmacists, but people have run out in a very short space of time. It needs to be longer. We needed a GP there or a pharmacist to say, no, you need to prescribe for longer, emergency prescriptions for longer. So often when I'm at these meetings, people will say things like, oh, mental health, we don't have mental health support. And I'll say, well, GPs actually can do mental health. They do. The majority of mental health in Australia presents first to general practitioners. So there's not that understanding by GPs about disasters and disaster management. There's not the understanding backwards, although I think it's increasing. And I think the way to bring that in is through what was mentioned before, standard procedures about what the roles are, how that will happen, how we'll communicate, and what's not in scope, which is why we're working on evacuation guidelines. What's not in scope for GPs is managing a large number of people who are going through alcohol withdrawal or major mental health issues. That's out of our scope, but we need to tell people that because people don't know that. And then just very briefly on the billing systems and the computer differences, that's been an issue that's actually been partly addressed by the My Health Record in Australia when that works. The other way we've managed it is through triplicate with carbon paper, where the actual information of the patients that were seen by GPs actually went back to their practice, and then a copy was kept elsewhere. So I hope that answers some of your question, and will be great to see you in Ireland.
Thanks for that. Well, we have one more person in the remote audience with their hand raised. Graham Dodd, I'm going to go ahead and unmute your mic. You there?
Great. Yeah, can you hear me?
Yep, loud and clear.
Excellent. Wow, wonderful presentation, guys. It's great to see you all. It's great to see you, Penny, again. You know, such a timely presentation, right? And I love the focus on primary care, general practice, and disasters. And you know, we're probably in Canada. I'm in the interior of British Columbia. So in Canada, we're probably a few years or so behind Australia, and maybe a decade behind our colleagues in New Zealand. And so one of my questions is, you know, how do we better share information between all primary care internationally, right? So I think you've answered some of the questions, like through the special interest group, and I think we need a better system, because a number of the things you've talked about that you've been doing, we've been doing as well. And so it's, you know, let's not keep reinventing the wheel. Let's share ideas, right? And let's bounce things off each other. So a better way of sharing information. And the comment about you know, disaster managers not understanding what the role of family doctors is absolutely applicable. They got a bit of an idea what happened after COVID, but complacency comes in very, very quickly, right? You know, a year later, they're going, well, we probably don't need you involved anymore, right? So I think we need to figure out how we maintain. So I'd be really interested in you know, pearls or thoughts you have on that, right? And, you know, even in Canada, you know, Kaitlyn, how do we share information across provinces? Because our healthcare system in Canada is very provincial, even though it's under a federal framework. And so our approach is very provincial. And so how do we share information amongst ourselves? So that I just wanted to comment on the great work you've been doing. Maybe I'll get to Ireland. We'll see. But just thoughts around complacency and how do we continue to convince our disaster management colleagues to include us?
That's a great question. I can go first. So I think part of the challenge is keeping it topical. And, you know, when we're in the middle of response, it's not the best time to start building these relationships. So I think as we move into more of a recovery sort of space and preparedness, I think that's where we should be focusing, is building these relationships across the different platforms, so that we've got something to rely on in the next crisis. And I think in terms of the SIG, that's what we wanted to do, and sort of where we started was we want to bring together some of these resources and share it across from what we have in our backgrounds and our research, but also across everyone's wealth of knowledge. So I think that's a great place to start. And then we're open to all sorts of suggestions and collaborations and anything to get this space moving. I think it's still very much in its infancy, even though that's kind of quite shocking to all of us when we first got into this, is how is it still in its infancy? Because we need primary care. It's such an important element. Libby or Penny, you got anything to add?
Can I respond? Graham's amazing. So I know Graham well, and he has done a huge amount of work. So New Zealanders, and then there's Graham in Canada. And I'm very aware of all the great work he's been doing. And we've collaborated a lot with the New Zealanders and with Graham. And I agree, you know, it's been hard to keep up and keep contact. And I think it's really important that we do have that. I mean, one of the things we haven't done through COVID, but we probably should start doing, is having regular teleconference meetings with the SIG. And in that way, we can actually then have conversations, and maybe we might do that twice a year or something, and then have extraordinary meetings as needed. So that may be one way around that. Definitely always, you know, as you know, happy to email at any time. But I think it's really important that we do know what other people are doing. So one of the other things I would suggest for our SIG that we could do, and this was also something we were considering, was we really need I guess a hub of disaster resources. So we've got a lot now in Australia. So those that we can share, we would like to put up. And then if there's others from other countries or other experiences, then I think we should put those up. The other thing, Graham, is we'll ask you to write in the next newsletter. So that will then be up on the website. So really great to have you on board, and really respect all the work you're doing in Canada.
I'll just add one more thing in terms of that complacency. That I think that we all feel a disaster event happens, it's all we talk about. And then when we're in the community, it sort of fades away and we forget about it. And maybe we lose some of our preparedness and our lessons. Just from talking to various sort of small regional and rural pharmacies and GPs, something that I've seen a little bit of is pharmacies meeting up with their primary care colleagues, even just quarterly, for like an informal dinner. They'll just be like, every quarter we're going out for pizza on a Friday and we're going to talk about disaster stuff. So they sort of lighten it, because disasters can obviously be quite heavy, with a little bit of niceness, something like a pizza. And it gives them an opportunity to sort of talk about challenges that have been happening in their practice every day and how they can help each other and how they can liaise. But then they also have disaster management stuff on that agenda. Like, okay, so we've had this big change in our practice, or this big change in what's been happening in our community. If a disaster were to strike tomorrow, how does that change what we're planning in terms of responding and together? So that's something really nice that I've sort of seen probably 2 or 3 communities doing, but I don't think things like that are widespread. And in big cities, it's quite challenging to meet with every pharmacy and GP and get them all together to talk. Yeah, but that's something nice that I've seen. Just wanted to share.
Well, we have, well, we're approaching an hour. Do the 3 of you have a few more minutes? Okay.
Sure.
We'll try and take just a couple more questions here from that've come in over the Q&A. We have a question here from Justin Bays, and Justin says, on a personal primary care level, when seeing patients or clients, how do your scripts or interactions change before a known event and post-disaster?
Does someone? I'm happy to answer that, unless Libby or Kaitlyn. No,
You can start if you like.
I'll start. Yeah. So look, when we're seeing patients in general practice, say there's a bushfire coming, interactions definitely change around discussions around preparedness. Do they have a to-go bag? Are they going to be leaving early if there's smoke? So we've had a huge experience with smoke recently in Australia during those bushfires in 2019, and the whole east coast of Australia seemed to be covered in smoke. It was horrendous, flying over the top, and a lot of respiratory conditions were exacerbated, so COPD and asthma. And so in that, if a patient comes in for a script, sorry, apologies. So if a patient comes in for a script at that time, I would actually be discussing whether if the air quality is not good, that they need to watch that and they need to think about evacuating earlier. So I think that was, that's one of the key things. It might actually tip you to do some other management besides just look at the script. And also, if they're coming in for a script at that time, I would be giving them repeats, and I would make sure that they have those in their to-go bag. They have more medication than they normally need. And then post-disaster, I think is really crucial. And as I said, I think this is a key area for GPs and pharmacists. This is when we're watching the deterioration of disease. So if someone comes in with a script for insulin, for example, and they've got diabetes, I might want to do a review of their, check their blood pressure, that might be raised, make sure we check the heart rate, make sure we then think about doing a check on their diabetes, so hemoglobin A1C earlier than normal, and we will monitor that over time. So I would use that as a touch point for reviewing their physical health, their mental health, and their safety and their living circumstances. Again, we know if they're in an evacuation centre, their diet and their exercise level will have changed, so their diabetic control will have changed and other things will have changed. So it's when we see those, each individual person, if they're in the realms of a disaster, we absolutely change our management. It's a great question. Thank you.
Yeah, definitely. And just to add to what Penny was saying in terms of sort of a pharmacy background, is really making sure that there are either an excess supply of medications to cover the disaster time, an updated list of what their medications are, their healthcare providers, those sorts of things, to make sure that they, one, know what they're on if they get evacuated and they're separated from their medications, and things like that. Especially in North America, where a lot of medications are covered by insurance programs, is making sure that patients do have a good reserve, of roughly about 7 days to cover for an emergency type event. We can sometimes be challenging in terms of getting refills and getting them covered as well.
Definitely. And just to add to that as well, the scripts, having worked in a regional hospital after a cyclone, we saw a lot of people rationalizing their medicine. So maybe they were on 2 pain relief medicines, but because they couldn't get into the GP or the pharmacy to get refills of that, they ran out of one, and so they just doubled the dose of the other, which then resulted in falls, head injuries. It just goes on, and then they're admitted to hospital, need a neurosurge assessment. nightmare. So I think that availability of GPs and pharmacies is really important, so people don't have to resort to rationing or experimenting with their medicines a little bit during the disaster. It's really important, because otherwise it just blows out, really.
Thank you for that. Well, I think we have time for maybe one more question. I think this one's kind of an interesting one here. It's from Michael Gaither. And Michael says, primary care is often resource dependent, such as providing medications and medical supplies to patients. How can we work with industry/warehousing to foster relationships that can be helpful in emergencies that would otherwise make doing our jobs difficult in the absence of necessary supplies?
So yeah, no, go ahead, Kaitlyn. I was just going to say, one of the things I guess we pride ourselves in primary care is that we're often able to work in resource poor conditions. And so we do manage to do a lot of stuff without, I totally agree with what you're saying, but we also manage to do a lot of stuff without resources. So, you know, post disasters, the sort of things that might happen is, I remember a GP in a bushfire in the Blue Mountains, 7:30 a.m. the next day, he turns up to work early, and there's a family covered in ash and soot, and they're turned up to their GP because they don't know what to do and they're distressed. And then after that, they had 2 weeks of people who were distressed, they were just calming down. The people felt safe. They felt with a trusted health professional. They were getting their medications. They were anxious, but the being in the waiting room felt safe. Some of them didn't have their home, so they felt safe in that environment. All that done without any resources, of course. And then they were reviewed and provided things. Resources are still, though, really important. And I think particularly if I go back to the infrastructure issues, you know, things like not having the computer system working, not having a room to sit in because it's been flooded and it's moldy and it's not appropriate. GPs after the earthquake in Christchurch, I remember their stories around, you know, turning up at the practice and everything was on its side. It's like someone shaken it and having to put stuff in place, but then having lots of broken things, having vaccines no longer working because of fridges. So I think it's almost like doing it's almost like as primary care, we need to sort of work out what we would need in that event. And then, yes, we need to approach groups to try and work out how we can. And I think groups are actually quite willing to do that if they know exactly what that is. I've spoken to electricity providers and they're like, yes, tell us if there's a GP down post-disaster, we really want to help them, but we need to know, and how do we know? So again, it's around those communication lines.
Yeah, definitely. And just to add to what Penny was saying is making sure that we do our due diligence, like with our business continuity plans and our disaster plans, to go through that process of what resources do I need in terms of backup power, or how to still run a pharmacy, or I know plenty of stories from where people have moved their pharmacy out into the parking lot and provided the service from there. So as Penny said, primary care is very good at adapting to the needs of the community and with the resources they have. The other thing is collaborating across primary care, because quite often there's stories of, you know, I didn't have enough stock for this specific item in terms of my pharmacy, and my patients didn't have it, but then the pharmacy down the road that might have been impacted and couldn't open had the stock. So I might have been able to operate, but they couldn't, but they had the stock. So being able to collaborate across those different groups and in your communities to make sure that we are pooling our resources to respond to the need as required.
And I think that touches really nicely on the need to have human resources allocated to communication in primary care disaster response. So often we're so focused on seeing the patient in front of us, we don't think about calling up the other pharmacy or calling the GP. It can be really challenging to make that space. So whether that's allocating someone specifically to just be answering phones or running across town to talk to the GP or the other pharmacies or check if they have this stock or that stock is something that I think is quite easy to forget when you've got a line of 20 or 30 people standing in front of you needing assistance.
Great, thank you so much. I think we'll have to wrap it up there. Libby, Penny, Kaitlyn, thank you so much for preparing this and taking the time to share your insight and talk about the SIG and the Congress. We really appreciate it. And thank you to everyone in the remote audience. We had 70 people for this discussion, which is a really great turnout. So really want to thank everyone for taking time out of their day to participate in this. And I was really quite happy with this sort of panel discussion / fireside chat. We were trying to come up with a name for it. I think it was really engaging, and just really thank everyone for being a part of this.
Thanks so much.
Thank
Andrew.
you for having us.
Thanks very much.
Please,
Thank you,
yeah,
everyone.
join the SIG, and any questions we didn't get a chance to answer, feel free to email through to us, or bring them to Ireland, and we'll see you there.
Yeah.
All right.
Everybody, bye-bye.
Thanks, Andrew. Bye.